We have a 45-year-old woman who has a history of chronic headaches and an umbilical hernia. She's being evaluated in pre-op clinic for a hernia repair. And besides her headaches and abdominal pain, her review of systems is unremarkable. She takes amitriptyline and acetaminophen, and her vitals are normal. So you review her prior abdominal CT and note that she had an incidentally found 4-centimeter left adrenal nodule. And she's never undergone any hormonal testing for this nodule before. So you decide to rule out a pheochromocytoma prior to surgery with metanephrin testing. So which of her following meds should be held prior to testing? Is it A, her amitriptyline, B, her acetaminophen, C, both of them, or D, neither? Take a few seconds. All right, so it's going to be both of them. Let's review pheochromocytomas today and find out why that is. First off, pheochromocytomas are neuroendocrine tumors that are found in the medulla of the adrenal gland. And when they're located outside of the medulla, they're called paragangliomas. These tumors produce and release lots of catecholamines, namely epinephrine and norepinephrine. And we all learned about this classic triad of symptoms where patients present, when they have pheos, they present with episodes of headaches, palpitations, and sweating. The problem is most patients with a pheo do not have this triad. And in one study of over 200 patients who had a confirmed pheo, less than 25% had this triad. And in another study, which was a meta-analysis, they calculated the sensitivity of this triad to only be 58%. So while my made-up patient didn't have this triad either, she did have chronic headaches and she did have an incidentally found adrenal nodule. So in order to confirm whether or not this nodule is a pheo, we have to do metanephrin testing, which is we have to try to find metabolites of catecholamines. And we can do this either by ordering a blood test or a urine test. And the blood test is generally considered to be more sensitive, whereas the urine test, which is a 24-hour collection, is more specific. An important thing to know about these tests is what can cause a false positive result. The plasma test is especially prone to coming back with false positives, which unfortunately can then lead to further unnecessary and costly testing. So for both of the tests, the plasma and the urine, there are many substances that we can ingest that can lead to falsely elevated metanephrin levels. These include things like caffeine, alcohol, and other substances. But there are also many medications that can do this too, like TCAs, SNRIs, and acetaminophen. Medications like TCAs work by inhibiting norepinephrine reuptake back into the neuron, which can then increase levels. And acetaminophen, on the other hand, it doesn't affect catecholamine metabolism, but it can cause interference with the assay itself, depending on what technique the lab is using. For plasma metanephrin testing, there are additional factors that can lead to false positives. So ideally, this test is done first with the patient lying flat, then having an IV line placed, then having the patient rest for 20 to 30 minutes, and then finally, after all that, drawing the lab from that IV line. Doing all these steps helps to minimize sympathetic activation, which can minimize your risk of getting a false positive. There have been studies done that confirm drawing the lab while the patient is seated upright does in fact lead to higher on average metanephrin levels, which can then raise the rates of false positive tests by about threefold. So if you're going to order the plasma test, keep this slide in mind because you should really consider even calling the lab to see if all these steps can be followed, if all this can be feasible for your patient. If not, you should strongly consider ordering the 24-hour urine test instead. So in summary, we learned that the classic triad of episodic headache, sweating, and palpitations is both uncommon and has relatively low sensitivity in detecting a pheo. And when testing for a pheo with a plasma or urine metanephrin test, we should be wary of what can cause a false positive. For plasma testing, this means making sure the blood test can be done with the patient lying flat and after a period of rest. And for both forms of testing, this means reviewing that med list really carefully to try and catch any common culprits that can cause a false positive result. And then if they can be held safely prior to testing, that should be done. And that's all I got.